Okay, so I guess I can go ahead and get started. So my name is Sharita King. I am an assistant professor going for associate professor at the Medical College of Georgia in Augusta, Georgia. I am the director of prosthetics and sexual medicine at my institution. I also work part-time at the VA. And tonight I will be talking on how I was able to harness female sexual medicine to build an IPP practice. Okay, so during residency, I like to think of me practicing in the dark ages. At that time, I believed I had nothing to offer women for sexual dysfunction as a urologist. If a patient came to me and wanted an IPP, regardless of what his partner's wishes or concerns were, he was going to get it. I felt like difficult partners were something that you just had to deal with. But then I ended up at the House of Goldstein at the San Diego Sexual Medicine. And there, our motto was that we not only learned about male, but also female sexual dysfunction. And both of these things were equally important. And from that, I was able to see the light. And once I saw this light, I figured out that I was able to treat these women. And then I got out and went to practice, and I wanted to figure out how I could take this newly found power I gained with my knowledge and applied it to my practice. So Maria is going to go more into why this is important for every urologic practice, but I just wanted to put this slide in here because this is why I think it's important. Because if we're looking at the PRESIDE trial, it showed us that the prevalence of female sexual problem with distress is about 12% of any type of dysfunction. So that's whether it's desire, arousal, or orgasm. So this is something that we need to be looking at because you will come across these patients in your practice. And it did open my eyes and open my practice and my world to a whole new set of things that I can treat in patients. So me always loving the prosthetic world, and the reason why I went into urology was watching the penile prosthesis as a med student. I always knew I wanted to build a robust practice. So my next goal was to figure out how could I harness this new knowledge and build it into an IPP practice. So the first way that came to my mind was that these patients that I'm seeing for female sexual dysfunction can be a source for IPP patients. So if you are seeing women that have GSM, so genital urinary syndrome of menopause, or vestibulodynia, which is pain in the vestibule, which Maria will go into, then there's probably a penis out there that is hurting them. So it is important that we ask these patients about the quality of the erections of their partner. So this is the article that came out when Viagra first hit the market. And this is what gave us the EHS scale that we use all the time for patients to try to figure out how rigid their erections are. And what they found in this is that the lower on the EHS scale that the penis was, that the softer the penis, the less successful that they were going to be at having sexual intercourse. So yes, some of it is due to soft erections, but some of this unsuccess or inability to have successful intercourse is because they're probably causing their partners pain by pushing rope. So how do we talk to our patients about this? So I kind of go through it like I do with my male patients. So either you can use the 4-point scale, like the EHS, where grade 1 is some fullness, grade 2 is fullness, but the penis isn't hard enough for penetration. 3, you have a more rigid erection. It's hard enough for penetration, but it's not completely erect. Or 4s, which is a fully rigid, which is ideal because when you have a grade 4 erection, it's able to glide in and out of the vaginal canal as it's supposed to and not cause undue friction, which is going to cause pain for our patients. So if y'all have the little Pfizer tool, I couldn't find a picture of it online, but it's a little tool that has like these 4 little cylinders on it that patients can actually feel. It allows them to have a tactile marker for what the quality of the erection is. Another thing that I do for patients at the VA, because I do not have this nifty Pfizer tool when I'm at the VA, is that I do percentages. So 50% is what I call like a grade 2, where the penis is a little bit rigid, but it's not standing up on its own. 100% is fully rigid. And I usually have a pin in my hand and say it's like it's a pin and it won't bend. Or you could do like a 10-point rigidity scale. Now, this is one that I will use on some patients who really are not grasping the numbers that well. You can liken it to food. Now, in my patient population, if I start talking about tofu, most of them will glaze over and have no idea what I'm talking about. So you got to, adapt this to your patient population. So I typically, for grade 1, will say a marshmallow, grade 2, peeled banana, grade 3 is an unpeeled banana, and grade 4 is a cucumber. So once you're able to ascertain what their erections are like, if you notice that there is an issue and they do have erectile dysfunction where their penis isn't hard enough, they're having a hard time achieving an erection or even maintaining, then you bring that patient into the fold of your practice, which I have done a lot. So the next thing that I was able to use to harness this knowledge of female sexual medicine is trying to prevent partner prosthesis panic. So what do I mean by that? I always have encouraged patients to bring their partners to the appointment. But I noticed that a lot of these women had a deer in headlights look when you're discussing the IPP with your patient. And I didn't have a name for it before I went to fellowship, but once I got to fellowship, we called it partner prosthesis panic, or PPP. So I presented on this at the 2016 AUA. And what we did is we looked at the last 50 IPPs that we had done when I was there. And we found that 11 of the partners, 22%, with a mean age of 57, which is important, expressed partner prosthesis panic, where they were afraid of their partners having surgery because of the fear of pain with intercourse or issues that they were having with sexual dysfunction. When we found these once we identified these patients, they were treated at SDSM via the biopsychosocial model that we use there. So the results from this, 82% of these women were menopausal and 18% were perimenopausal. So that's all the patients. So remember, I said their mean age was 57. So that's important to think about when you're seeing these patients. All of these patients had FSD for greater than 5 years prior to the penile prosthesis surgery, and all had abnormal FSFIs and sexual distress scales. And once we identified these patients, they, like I said, underwent the biopsychosocial model, where during their psychologic interviews, we found out that 27% of them had sexual trauma or abuse. 45% had some sort of mood issues with anxiety, depression, panic, and they were using some sort of mood related medications. We also have a pelvic floor physical therapist in the office, and 73% of these patients had abnormal exams of the pelvic floor. So then for our portion, we did vulvoscopy. So that's when you actually look at the genitalia of the women, and then we were able to find that in all 11 patients, they had evidence of genital urinary syndrome of menopause. So again, remember, these women were 57, was a mean age of 57. So what we found is that when we were able to treat these patients, then they were ready to receive the erection that we gave their partners after the prosthetic surgery. And then this in turn improved our patient outcome. So once you have treated these women, now you're able to form allies with them. So why is this important? This is important because partners can be the gatekeeper. They can either be your biggest ally or your worst enemy. If you ignore them, then they can totally halt progress and prevent you from getting to the promised land of a penile prosthesis in your patient. So how can partners be allies? There's a couple of ways that I have found that this is critical in my practice. One, they can be an historian. They can provide information that the patient has forgotten. They can provide information that the patient finds embarrassing to relay themselves. They can also be a fact checker, because we've all had those patients come in and be like, my erections are okay. Like, what does okay mean? And you look over in the partner, and the partner's like, yeah, he's not getting them, and shaking their head. So that's one of the ways, just being my historian. Another way is by providing support to our patients. So even though these patients are coming to see us for erectile dysfunction, when you deliver the news that they may need surgery to correct their problems with erections, they go into mourning for their erections. And the partner can be there to be support to help them through that process. The other way that they provide support is by calming their anxiety. So the patient is very anxious about the surgery, then the partner can help them kind of calm down and understand that it'll be okay and they'll make it through this and they're in it together. Another way that partners can ally is that they're a second set of ears. When you're setting up patients for surgery, you are telling them a lot of information. You are discussing what they need to do pre-op, what to expect on the day of surgery, and what to do post-op. A lot of times this information is going in one ear and out the other. So having that second set of ears is another person that can kind of bring back those points that you have talked about with the patient. The other thing is that I find most of my partners are providing post-op care for our patients. So you want them to be on board, and you don't want the first time you're meeting them is on day of surgery. And then lastly, I've had some patients who don't have the best dexterity, but still wanted an inflatable implant. So it's important that if they have a partner, that they are there so they can help with post-op cycling. So as we discussed, if you improve the female partner's sexual function and then you have them as an ally, then this will improve your patient outcome. So why is this important? Because studies have shown that patient outcome directly correlates to partner satisfaction. So it would behoove us to make sure that these partners are in the conversation and ready to receive an erection. This review article looked at factors that affect patient outcome, and they identified 3 categories: pre-op, intra-op, and post-op. And then when you looked at the post-op factors that went into it, partner satisfaction was a huge role. Okay, so again, we want to make sure these ladies are happy. And then this article that was that I found actually through the journal Urology, because they had editorial comments on it. So I went and found the original article. They shown that they were investigating the effect of penile prosthesis on the sexual functionality in patients and their partners. They had 20 male patients that were status post penile prosthesis between 2013 and 2018 and their partners. So they had them complete the Arizona Sexual Experience Scale form before having the surgery. And then after use of their implant, they had 20 patients and 19 partners complete a modified EDITS, which is the ED inventory treatment satisfaction, and the ASEX, again, at 6 months follow-up. So the thing that they found here, the average age of the patient was 54, average age of the partner was 43. After surgery, the post-satisfaction ratio was higher in the female partners than the males. And then there was also a significant improvement in the total score of physiologic stimulation, orgasmic capacity, and satisfaction in both groups. So it's very important that we are including these female partners in our conversation and making sure that we are using all of the knowledge that is at our fingertips to make sure that they're happy, because when they're happy and they have better outcomes, so do our IPP patients. So in conclusion, if you can find a way to learn female sexual medicine, once you start treating those patients in your practice, they can be a source of patients for your IPP practice, which will in turn, if they're the source of it, then they're probably going to be an ally, and that'll help build your practice. But then if you're actually treating patients, partners, then you're going to prevent them from having patient prosthesis panic. You're going to form an ally with them that'll improve their patient outcome, and in turn, that will still build your practice. So that is how I was able to harness the power of female sexual dysfunction or female sexual medicine into building my IPP practice. Any questions? All right, so if we don't have any questions, then I'm going to turn it over to Maria.
Hello, everyone. How is Dr. King? Amazing, amazing talk. Always lovely to see your face. So I am going to spend a little bit of time talking about why, as urologists, we should care about this. Not only as sexual medicine doctors, but why, as urologists, we should care about this, because they're so, and Sharita talked briefly about GSM and vestibulodynia that masquerade as very common urologic conditions. And this is actually something that has totally enhanced my practice. I am an assistant professor at UCSD, and I have a comprehensive practice. I am the director of the Vulvar Center, and also see my penile patients as well. And we're, in the talks of opening and collaborating on a couples clinic. And I still do about 10% of general urology, 10 to 15% of general urology depending on the day. And this has really enhanced my practice in ways that I never thought possible. So many of those really difficult patients, not the patients, but their symptoms, those difficult symptoms that made our lives kind of hard and difficult because we just didn't have good answers for them. Having and incorporating this practice of sexual health has changed my practice patterns completely. So I'm going to share my screen. See, we're going to do advanced portion of screen. Okay. And all right, excellent. So like I said, why should the urologist care about genital pelvic penetration pain disorder? These are my disclosures. So, let's talk about this. The female sexual dysfunction or vulvar sexual dysfunction, some of you might be thinking, I'm a urologist, I'm a sex med doctor, which, if we think about it, sex is a team sport. So why are we not taking care of both sides? And one thing I'm going to tell you right now is that when we think about how good urologists have been in terms of advocating for our patients' sexual health, that it's not necessarily the same diligence that is within the gynecologic space in terms of sexual health. And so my challenge for all of us is that we take up that burden, because if you talk to patients, they have such difficulty accessing care. And obviously, even our governing body has seen that we do play a big role in female sexual pain disorders or vulvar sexual pain disorders. And so we really have to start owning this as urologists. So what is genital pelvic pain penetration disorder? So this is at least 6 months of marked vulvovaginal or pelvic pain during penetrative intercourse or penetration attempts either associated with anxiety or marked tensing or tightening of the pelvis. And this affects up to 25% of people in the United States. So the most common causes of GPPPD found in urologic settings are genitourinary syndrome of menopause and a condition called vestibulodynia, which prior to fellowship, I'd never heard of. So that's what we're going to really focus on today. So I would love if people could drop in the chat who's heard of this condition. And I would also love a show of hands or drop in the chat who's even heard of the vestibule, because prior to fellowship, I had not. Let's see, chat. Sharita, okay, thank you. Again, it's a condition that we do not learn about as urologists, and I think it's actually such a detriment to our patients. So this is the vestibule. So this is a slide presented by the illustrious Dr. Irwin Goldstein at the most recent AUA, and this is an amazing example of what the vestibule looks like. So the vestibule is an endodermal structure located between the labia minora and the hymen. It contains the vaginal orifice, external urethral meatus, and then also contains vestibular glands. The most common ones are the Bartholin glands, but it also has minor vestibular glands that are important for sexual lubrication. So this is an endodermal structure that's very completely different from the rest of the vulva. It has lining similar to the bladder. And, it is a structure that is rich in testosterone receptors. So we always talk about estrogen, 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 but actually the adrenal glands and the ovaries make about 1,000 times more testosterone than they do estrogen. And so this is where a lot of the times when you cross over to female sexual health, you start realizing how societal dogma oftentimes will start clouding objective evidence. And so just really want to hone and stress that there is more testosterone receptors in the vestibule than there are estrogen receptors. And so this plays a huge role in our treatment algorithm, but I want to get a better understanding and kind of really talk about testosterone production in the ovaries and in the adrenal glands. So adrenal synthesis happens 50% in the ovaries and 50% in the adrenal glands in women. Of the testosterone that is produced, testosterone and dihydrotestosterone, 25% coming from the adrenal glands. And so what are considered normal ranges of testosterone in women? This is actually from a study conducted by Bronstein et al. That looked to identify the normal reference ranges of testosterone in women. They measured the serum free total and bioavailable testosterone, as well as the sex hormone binding globulin in normally cycling women between the ages of 18 and 49. And based off of this, they were able to calculate what the average production rate of testosterone in a premenopausal 30-year-old female. So how does this compare in relation to estrogen production? Because as we know, estrogen is touted as the female hormone, but in actuality, we are rampant in testosterone just as much as we are in estrogen. Yes, there is that conversion of testosterone over to estrogen, but if we really look at it, and one thing that's really interesting as a provider is that you'll see that estradiol is actually reported in picograms per milliliters versus oftentimes testosterone is converted into nanograms per deciliters. And if we do those conversions time and time again, you will find that you are actually producing way more testosterone than you are estrogen. So quantitatively, the ovaries and the adrenal glands secrete greater amounts of androgens versus estrogens. Now, what does that actually mean for us in terms of bioavailability? So when we think about bioavailability, what we want, what our goal number is 0.6 for 0.6 to 0.8 for bioavailable testosterone, and that's going to come into play later on as we go down the road. So what is vestibulodynia? So what it actually means is just pain in the vestibule. This can occur at various times, either during or after penetration. It can occur in certain positions or may occur just unprovoked. So the common symptoms of vestibulodynia include burning, stinging, pressure, irritation, broken glass, vibration, rawness, urinary urgency and frequency. And, I really want to spend a lot of time talking about the symptoms because these symptoms sound very familiar, right? These symptoms are symptoms that mimic conditions that are kind of very difficult for us to treat. So these symptoms mimic interstitial cystitis, they mimic recurrent urinary tract symptoms. Um, they mimic the urgency, the frequency. They mimic the patients with postcoital UTIs. Unless you are, using some really unsanitary practices during sex, it does not make sense as to why every time you have sex you get a UTI. But it does make sense as every time a penis, a penetrative object, because it doesn't necessarily always have to be a penis, goes through the vaginal canal, but has to go first through the vestibule, which is red, raw, irritated. Of course, it's going to feel like symptoms of a UTI. Of course, it's going to burn. Of course, it's going to hurt. And then you get antibiotics because you don't actually go to the doctor. You just go to an urgent care. And guess what, team? Antibiotics have very anti-inflammatory processes. Not only are you treating an infection, but you're also decreasing inflammation just with the administration of antibiotics. And this is an inflammatory process. So that's why people feel better as soon as they start taking antibiotics, because of the anti-inflammation, not because of the fact that they have a UTI. So, the question, and I'm very similar to Sharita in terms of, I went into this particular specialty and because I wanted to do prosthetics. I wanted to be able to help, men be able to do a really important part. But then through my fellowship, I realized that, like, oh no, I should be able to take care of both partners. Sex is a team sport, and I want to be able to take care of everyone on that team, regardless of who they are. So, let's talk about how common this is. So vestibulodynia was first described in 1987. So it's still a fairly new phenomenon, although it's been probably present for forever. And it is actually one of the most common causes of pain. So of the symptoms that cause GPPD, vulvodynia is the most common type of GPPD, but vulvodynia is just a broad term, meaning that there's just pain in the vulva. But vestibulodynia actually happens to be 90% of patients with vulvodynia. And this affects up to 6 million women in the United States. And that number is expected to increase as we have an aging population. Because guys, guess what? Who gets this condition as well? Menopausal women. All menopausal women will have some degree of this. Vestibulodynia is just GSM, as just another name for GSM. So it's all the same conditions that we're treating. And unfortunately, despite it being a really common thing, patients have such significant burden to get diagnosis and to get treatment. So a study found that 60% of people with vestibulodynia consult at least 3 or more doctors just to get an accurate diagnosis. They're oftentimes going to their gynecologists, their urologists, dermatologists, and even primary care providers for these symptoms. And even when they are able to get diagnosis, then treatment variability within the world of vestibulodynia is so high that they oftentimes don't get treatment success. And this has been so detrimental to the patients. Significant emotional and psychological burden, and then anxiety, depression, decreased self-esteem, sexual dissatisfaction, and decreased quality of life. And as implanters, we care so much about quality of life. As implanters, if we want to be able to grab and capture that market, we have to be caring about their partners. And this here is a slide talking about the financial burden for a lot of patients. Just to get access to care, this condition costs about $31 to $72 billion annually. And we're not even talking about the patients that are getting side effects of being constantly treated for UTIs and the downward side effect stream that comes from that. So how do you diagnose this? So this is one thing that is really important, and I really want to stress of how important a physical exam and knowing vulvar anatomy is. We think we know as urologists coming out of training that we know vulvar anatomy, but we really don't. We hyper focus on one particular piece of the vulva, but when in actuality, we need to step back and examine the vulva in its entirety. This also condition is super easy to diagnose. It's really just getting an accurate symptom onset, duration, characteristics, really just pain. The things that we learned initially as we were going through training is just getting an accurate history. And then labs are going to be your best friend. So really a comprehensive hormone panel. And this is the hormone panel that I recommend, because really, like I said, this is oftentimes driven by a low testosterone state. So this is a video I'm making for the AUA about the vulvar exam. I'm just briefly going to talk it out. I mean, this is something that you can do in less than 5 minutes. I do this in my cysto for patients that are coming in with recurrent urinary tract infections. So what I'm doing is I'm just taking a look at a general vulvar anatomy, making sure there's no obvious skin lesions or changes. Next thing I'm doing is I'm looking at the interlabial sulcus. So things like lichen sclerosis is going to be living in that area. And you really want to be able to capture that because lichen sclerosis is associated with vulvar malignancy. So really capturing that and at least getting them to the correct provider is super important. Next thing I'm doing is I'm measuring labial length. In theory, it should be about 3 centimeters in length. Also, what I'm doing now is I'm checking for resorption. So as women age and as people with ovaries age, they start losing estrogen, and the labial length and resorption are very estrogen dependent. The next thing I'm going to do is I'm going to look at the clitoris. What I'm doing is I'm reducing the foreskin and I'm checking to see clitoral size. Small clitoral size is associated with low testosterone states. And I'm also checking for clitoral adhesions. It's a very common thing that no one checks for. No one examines the clitoris. Now, what I'm doing here is I'm looking at the vestibule. Everything from the very bottom of the clitoris down to the posterior fourchette is the vestibule, out to the Hart's line and down into the introitus here. And what I'm doing is I'm doing a Q-tip test. I'm touching at a very standardized way of, hey, do you have pain here? Do you have pain here? Do you have pain here? They shouldn't feel this. They should feel pressure, but not sensitivity. If they have pain in the vestibule, that is what we call vestibulodynia. And that is a condition that is easily treated as long as we know what it's caused from. Now, the next thing we're doing is I'm checking also for pelvic floor muscles. So what I'm looking for is I'm checking to see, do they have tenderness or pain? Also, I'm also checking to see what the health of the muscle is. So healthy muscle feels like the thenar prominence versus unhealthy muscle feels like the back of the knuckle. The last thing I'm doing is I'm doing a speculum exam. What I'm really doing for this is really just to show you some really important anatomy. You don't have to do a speculum exam for every single person. You can get vaginal pH in your patients that you have on vaginal hormones to see if they're compliant. But you know, these patients are so symptomatic. I have a high compliance rate. The other thing right now, what I'm doing is I'm showing you the female prostate. That's that structure that's hanging down. That's also something that's very testosterone dependent. And so also a great kind of anatomical landmarks to see what people's hormone status looks like. So we're gonna go next. So let's talk about vestibulodynia. So this is from a slide from a very pivotal book, When Sex Hurts by Dr. Erwin Goldstein and Dr. Andrew Goldstein. And this is a great diagram of how to, what are the causes? Now that you've diagnosed it, what are potential causes? And so I'm going to talk about something that is really common to us as urologists. It's hormonally mediated provoked vestibulodynia. So like I said, those are the patients, and for as a urologist, when we're thinking about this, those are patients that come in with IC. Those are the patients that IC, but with no Hunner's lesions, no diagnostic criteria to actually fit IC other than their symptoms. Those are the patients that have refractory OAB. These are the patients with postcoital UTIs. This is the patient. Spread open their labia and you will see this. You will see redness, rawness. You'll also sometimes see pallor. Depending on their state, this is something that will change your practice. You will have such happy patients when you're able to diagnose them appropriately. And so I want to also take into consideration what causes, the different causes of hormonally mediated provoked vestibulodynia, because this is a low testosterone state. So things like oral contraception, menopause, the patients that have undergone surgical menopause with oophorectomy, hormonal birth control for endometriosis, or breastfeeding. Breastfeeding sends you into a state of menopause or lactational amenorrhea, infertility treatments, acne treatments. And so, you know, the role of OCPs, ask your patients, have they or ever taken birth control? Because they might not be on something now, but if you've even ever taken birth control, it rests with your sex hormone binding globulin, which then decreases your free testosterone. We know that patients that have had any exposure to OCPs increases their risk of developing this condition by 600 to 900%. So, you know, this is really really, really important, and getting a really detailed history on the patients. And so, I talked briefly about sex hormone binding globulin, but anything that goes through first pass metabolism within the liver has the potential ability to increase your sex hormone binding globulin. And so these are just also different conditions and medical conditions that can affect sex hormone binding globulin is really important. So how do you treat this condition? It's super simple. Just give them back testosterone. So, there are estrogen receptors, but there are also testosterone receptors. So this is the one I use in my clinic. There is an FDA approved version of prasterone or Intra-Rosa that they can use, but some patients, due to cost, are not able to get that. And so I have them use this. I use it from a compounding pharmacy. Every night, they place about a pea-sized amount directly into their vestibule from the bottom of the clitoris all the way down, really making sure to concentrate into those glands. And I have my patients, as I'm doing my exam, I have my patients literally show me where they're going to put their medication, because you can tell them where to put it, but if they don't know, because a lot of you have never seen this anatomy, a lot of them has never seen this anatomy. If they don't know where to put it, they're not going to be putting it in the right spot. And you will be surprised the response rate for these patients. Within 6 weeks, you'll start noticing symptoms, 40 to 50% symptoms, and within 12 weeks of this treatment, complete resolution, which is just so amazing. And so this is also a study from Andrew Goldstein that looked at the response rate of 50 premenopausal women who had been on OCPs using this treatment, and found that the patients with post-treatment ET cream had significant less vestibular pain in comparison to the placebo group. And so this is an example of, after successful treatment, after just 8 weeks of treatment of hormonally mediated vestibulodynia with estrogen and testosterone, because we cannot forget how important testosterone is, how much treatment success that you get. And so this is a great thing to talk about in terms of research gap. There's so much research gap when it comes to vulvar health and vulvar anatomy, and we need so many more of you all getting involved in it. So in conclusion, GPPD is a very common and treatable condition. Vestibulodynia is one of the most common types of GPPD. Urologists, we need to be the forefront of promoting appropriate diagnosis and treatment. Free testosterone is more accurate means for diagnosis than just looking at your total testosterone, because a lot of times OCPs do not affect your total testosterone. And so people will say, oh, everything's normal, but actually if you really look at their free testosterone, it's markedly low. Diagnosis and accurate treatment is possible. And not only as a prosthetic surgeon, having pain-free partners is awesome, but also as a urologist, because your practice is not going to be sex med 100% when you start. So getting this into your practice is going to be so important. So these are my references, and if anyone has any questions, I'd be so happy to answer. And show. And I'm going to stop share there. All right.
Okay, you can probably, if you have a question, you can either chat it, or at this point, go ahead and unmute yourself and ask a question if you'd like.
Hey, Bobby, can you unfreeze my camera?
I can. What did I froze you?
Yeah, it took me out.
Sorry about that.
So does anybody have any questions at all? So I have a question for you, Maria, then. So I just on Monday saw a patient who is a daughter of a urologist, and she is having like all the typical symptoms of provoked vestibulodynia. And on Q-tip testing, she's positive on Q-tip testing. And her main complaints are that after she said she thinks she has a UTI, but her main complaint is she feels like she's in retention, and then she has blood. And I was like, "Are you sure this blood comes from your urethra?" So I did a cysto at the urging of her father. And it was just interesting because like, even though I know all the science behind it, and I'm sitting there like spouting off all the Kool-Aid that Dr. Goldstein has given me, all right, from fellowship, I still cannot convince her to allow me to try. I do have a lot of patients who are resistant to going on testosterone just because of societal, that estrogen is for women, testosterone is for men. What do you do for those patients? And what I have done is just like done it like an abbreviated, like a lot of my patients, I don't give systemic testosterone. They purely just get the cream. And that is like, that's my Frank's Red Hot. I literally put that on anything, like on any female. So what would you do for a patient like this?
Yeah, so I no longer prescribe systemic testosterone to every single person. It is a very specific patient that I subscribe to, but every single person gets ET cream. And I actually have started using this as part of my, complete workup. So for that patient whose dad is also a urologist, I'm sure they're like, she has hematuria. Oh my gosh, make sure she's not, she's not going to die, which totally makes sense, is what we know as urologists. So I incorporate it now into my microscopic hematuria. I incorporate it into my recurrent UTI workup. And that there was that recent study that showed that, doing cystoscopies is not all that helpful. But, as I'm doing a cystoscopy, I'm also doing my vulvar exam. I'm like, and it's more so for patients to be like, look, there's nothing wrong with your bladder. We've ruled it out, but let's look at your vulva. Oh my gosh, turns out it's actually vestibulodynia. Who would have thought? I thought, and we all knew. And so I think for them, it's also reassuring because it's like, well, they've looked everything up. And like, I even had a bladder cancer patient who had, low-grade TA and was on surveillance, and, she couldn't get in to see her urologist. So she came to me and was like, you need to scope me now, I'm going to die. And I was like, okay, like I'll get you in the schedule. And so she's menopausal. I scope her. Again, it's low-grade TA. The likelihood of recurrence, she's 4.5 years out with no recurrence. Like, I knew the likelihood wasn't high, but for someone like that, I'm not going to be like, no, it's your vestibule. Like, I'm going to scope you. And then found out there was nothing in there. And then she's like, but where's the blood coming from? And I was like, can I show you your vestibule? And so we did an exam together. Her vestibule is red raw. Like, if anything goes in there, of course she's going to have blood. Of course she's going to. And she's like, well, actually, when you come to think about it, yes, everything hurts. And I was like, okay. So these patients may not come to you specifically for sex or pain with sex, but they can come to you for all these random symptoms. And, incorporating this into your algorithm is like night and day. It truly makes you such a much more comprehensive urologist, I think.
Yes, I absolutely agree. It, like I said, going to that fellowship completely changed my management. Like, when I was a resident, we had an attending that saw all the women because nobody else wanted to. And we called it, this is so sad because I'm a woman. It was Crazy Wet Woman Clinic, but nobody wanted to go there because it was just, I had nothing to give them. And then this just completely changed the practice of myself and my NPs. I've had a hard time getting my other colleagues to adopt, but at least we're having some leeway and some change in our institution. Let's see, I think I just saw a question pop up. Oh, so yeah, I see you answered it. So there is not a questionnaire for vestibulodynia. And that's what we're talking about. Like, a lot, like all these patients, most of them won't come in and just be like, my vestibule hurts. They're going to say, oh, I have recurrent UTIs, or I feel like I have an infection all the time, or I have dryness, or it kind of hurts when I sit down. It hurts when I'm having intercourse. And you have to kind of tease through that stuff. A lot of your microhematuria, like postmenopausal women, is not just that they have low estrogen, it's because they're having low testosterone at the vestibule. Another thing that how I like to think about the vestibule, yes, it's very similar to the bladder, but it is almost analogous to your penile urethra, right? And what we've learned recently is that the penile urethra, like if you're doing urethroplasties, if you're doing AUSs and stuff, if their testosterone is low, your chances of it healing properly is lower. So that's why I think it's important for us to remember that we need testosterone for the vestibule.
Amazing.
I know. Sorry, I'm very passionate. Any other questions or comments?
Are you with preventative hormonal placement? Oh yeah, no, 100% preventative. Y'all, if you can prevent these patients from these symptoms, you will clear up your recurrent UTI spaces in your clinics, which then puts you to be able to have more patients in your clinic so that you can then see the people that you want to see, right? We could, again, I run a vulvar sexual health clinic. So this is, but my idea is that even if they don't come to me for, specifically GSM, if they're perimenopausal, I will start having this conversation with them and I will start saying, you need to start this so that you don't become my 80-year-old who wish that someone would have told her she needed to start vaginal hormones. Because one of the things that happens is as you lose, the longer you have no hormones on board, you literally start getting all of these structural changes, these physiologic changes that put them at risk for developing it. So why not start prevention early? 100% start them early, start having these conversations. Like I think it should, I'm trying to get the AUA to enact this stuff, but this should be part of like health maintenance screening, like we have PSA discussions with our patients, we should be having vestibulodynia and GSM discussions with our patients so that we don't have to see them in clinic over and over and over again and then be disappointed that we're not helping them.
I agree.
Oh, so lifelong. Lifelong.
Yeah.
So if you're a perimenopausal, postmenopausal woman or person with a vulva, you're going to be on this medication till your very last day. Very similar to how men take testosterone. We never are like, well, you're only going to be on it for how long? They're almost like on it for like indefinitely. This is actually, we're preventing significant structural changes that will ultimately lead them to a urologist office. So I tell them that this is going to be something that they're going to be on lifelong. If I'm just treating like my younger recurrent OCP patients, I tell them to stop their OCPs. I treat them for 3 months and then they can get off the medication at that point in time. But because their ovaries and their bodies will catch up, but my perimenopausal and my postmenopausal patients, their ovaries will never catch up because they're having that steady decline or they're no longer producing any hormones. These are fantastic questions. Oh, and these hormones don't raise your systemic levels.
Yes.
These are just only hormones for the vulva. Like they do not raise systemic hormones. If patients are like, I'm scared, what if I grow a mustache? It's like, well, one, you can tell them that they are actually rampant in testosterone. And then two, tell them that this isn't going to raise their bloodstream levels. And so it's really, really, it's safe and effective.
Let me see. I'm trying to share this old school slide. So this is a picture that I took when I went to interview for my fellowship. And I routinely will come back to it. So if you want to screenshot this, I don't use all of these things all the time now. I do like Maria said, I do very much tailor this toward each patient, but this is like the total management that you can do for menopausal women. And what I usually will focus on is the vestibular and the intravaginal. And then if they don't have improvement, then we start going to the other things that we can treat. So if they continue to have issues with pain despite this, then and they show that they have a low free testosterone that's lower than 0.6, then we can discuss doing testosterone therapy. It's the same sort of symptoms that men will have, where they have like low libido, it's usually low libido and the pain that I see with women. Wouldn't you agree?
Yeah,
Maria?
and the urinary symptoms.
Yeah, the urinary symptoms. And then if they say they're having hot flashes, then we can talk about doing if they choose to. But I usually I let like I let them know what the platter is, and I let them pick what they want to eat off that platter. So you want like a management, but that's like my go-to slide when somebody asks me about like what do you do for women with pain or women that are going through menopause. I'm quick to shoot that out and be like, look, this is what I learned, this is how I use it now, and go from there.
Oh, any special consideration regarding approaching? So can
go ahead.
Yeah, I guess I need a clarifier for that question.
Can you unmute yourself? We don't bite unless you ask us to.
Any special approaching?
Yeah, hello.
Hello.
Hi, everyone. Yeah, sorry just for this question. It's excellent topic. Thank you very much. So just about it, but just I have a question about regarding patients with transgender like problem approaching with like going for hormonal therapy like testosterone. Sometimes it's kind of offending for them. I had like many patients before when I want to start like testosterone therapy, they said no, like it's offending, and they are like they don't take it for this indication. I don't know if you have like any approach how to go for it. I know there is no systemic like effects for this treatment.
That's
yeah, so for transgender patients it's a little bit different, and I really honestly don't have a huge transgender patient population at my institution. I'm in the deep south. I am just starting to branch into doing like orchiectomies, but we do have a clinic that deals with hormones with transgender patients that just started. It's between family medicine and some of the providers from REI actually are running that, because it is different. Like we are talking about the vestibule in cisgender women who are having pain. And that's going to be different than your transgender patients who are transitioning from male to female, because it's not going to be anatomically the same. I don't know if that answers your question.
so, yeah. I'm curious. So is it that they're taking testosterone and then that they have vulvar symptoms?
Yeah, exactly. So vulvar symptoms after testosterone therapy, and they are considering them now. I have patients like men patients with vulva, and yeah, so with
You're talking
like
about so okay,
pain.
so
male.
Yeah.
Okay.
So what I would do, so in those scenarios, I try to break into so I really focus on the science, right? And so I start teaching them about the science of their bodies, no matter what they like in actuality, and in respecting what they want, but also then going into, okay, but this is actually what scientifically, let's stop thinking about hormones as a gendered thing and think about it from a scientific perspective. Look, this tissue, in order to be healthy, needs both estrogen and testosterone. And I think this is where you can make some leeway with them, is that that it's not just one or the other. You can tell them that, you know, you actually need both. You need both in order to be able to keep this tissue healthy. And so approaching it from a scientific standpoint is really something that I try to do with anything, because, you know, we're working in sex. Dr. Goldstein says we're like 1 degree away from smut. And so I think it's really, really important to almost take away societal pressures and just really focus, and while being very respectful of where they're coming from, and focus on the science at hand.
Perfect. Thank you very much.
Yeah, fantastic question. All right, team, you all have asked some amazing questions.
Yes.
Well, thank you so much, you guys. The hour is up, and Any follow-up questions? You know, I'm happy to share with the presenters tonight. I appreciate everybody's time. And I think that's it. Thank you so much, Dr. Loco and Dr. King. Appreciate that.
Yes. And good luck to all y'all starting your practices or wherever you're going off to. I'm sure you'll do great.
Fantastic. All right. Have a great night, everyone.
Bye.
Bye.